Right now, the standard for how to approach an EGFR patient over the course of their disease would be to start with one of the frontline EGFR drugs, either afatinib, gefitinib, or erlotinib, and then if progression developed, and if that progression was, as it usually is, via T790M, to go with a second-line drug like osimertinib, or a trial of one of the other second-line drugs that works against T790. And then at that point, if the patient developed resistance to the second-line drug, to switch to chemotherapy. Usually patients are still in very good physical shape, even though they've progressed through 2 lines of EGFR treatment, and can often handle a platinum doublet chemotherapy like carboplatin and Alimta or pemetrexed. And then, other options that are available to all lung cancer patients, second-line chemos like docetaxel, potentially immune therapy. Although I will say that with the new immune therapies, the PD-1 inhibitors, the one group of patients that really seems to have the lowest benefit are patients who are never smokers, and EGFR mutation patients are often never smokers. So immune therapy may not be as attractive of an option for EGFR patients. There has been over the years conversation and controversy, I would say, about whether or not to continue an EGFR inhibitor with some of these other treatments like chemotherapy. Do you just keep an EGFR inhibitor going for the life of the patient as they switch from different chemos or different other treatments? And for a while, we thought that the answer there was yes. Some more recent data in particular, there was a randomized trial that Tony Mock did called the IMPRESS trial, which suggests that maybe keeping an EGFR inhibitor going with chemo is not the right answer. We are waiting for some other trials, and there can be individual patient factors that play into it. But for the most part, it seems like a first-line treatment, and then second-line EGFR inhibitor, and then chemo. There are some ongoing trials that will help us figure out if the newer EGFR drugs like osimertinib should be moved up into the frontline setting. And there's a frontline randomized trial going on right now, FLORA, which is a head-to-head comparison of osimertinib, the resistant specific drug, with erlotinib. And this is given in the frontline setting. And we won't have the answer on that trial for another couple of years, but it brings up an interesting question about thinking about the whole sequence of treatments. And even if osimertinib has a longer PFS than erlotinib in the frontline setting, we'll have to think about, is it long enough that it would beat potentially erlotinib followed by osimertinib? So the sequencing and the order is starting to become something we have to think about as we have more and more drugs in our armamentarium.